So I mentioned, now the patient is all set, anesthesia given. So starting off with the first and foremost thing is position. So position, when you do a mobile bearing, you usually do a hanging leg, and when you do a fixed bearing, one might need a standard TKR position. So any changes, any deviation in that in your practice, starting with notation, sir?
No, definitely. In fact, I do even mobile bearing also. I do even without that leg holder also.
Okay.
So it basically, I will say it is, you have to leave it to the surgeon, because he has to be able to bend the knee comfortably and also extend it. One. Second thing is, he also should be able to change it to a total knee.
Total knee, absolutely.
Change it to a total knee. So that position should be the right position.
Correct.
So if he sees in fact I didn't add a lot of time, I didn't add in my talk. You see the lateral compartment, you view it little bit, and also the patellofemoral, trochlea, everything. Any doubt, don't proceed with the uni, go ahead and do a total knee. You see our knee will do a wonderful job. So for that, your position should be helpful.
Yeah, true. Nikhil?
So one more thing to add, actually, for a hanging position. So if you're using a bilateral uni in the same sitting, probably the hanging position makes a lot of problematic things for the patient.
Absolutely.
Put in the palsy kind of things, because it's in the hanging position in a little abduction and flexion. So there is a lot of stretch in the pudendal nerves, and so be aware of that position. So over the period we started with this position, but now I am again landed with the same TKR position, so that easily we can convert UK to TK if at all you want to convert on the table.
Bhupendra?
Yeah, correct. Initially I used to do mobile bearing in hanging leg, but when I started fixed bearing and started on straight table, and then I was confident, and now I do mobile bearing on that same position.
The counter argument from the Oxford guys is that you don't get the proper MCL feel, tension. They need to snap that poly in. So they say if it's not hanging leg. But then these problems, especially in a bilateral, you don't get the correct MCL tension, because the patient tends to be a bit eccentric on one side when you're using the leg holder. It's not a classical bilateral, tension. So, one should consider doing a hanging leg if you're doing exclusively mobile bearings. Otherwise you could and like Natishan sir said, it's a personal choice as well. Whatever you are comfortable with, try and apply that in your practice. But there's a learning curve where you understand about the tension that you get in between a hanging leg if you're doing a mobile bearing, tension and the MCL when you're doing a hanging leg versus just a standard TKR position.
One thing. So you can mimic that hanging position in a TKR position as well. Only one thing you require a good assistant guy who can grab the thigh,
for deep flexion.
And you can have a same feel, because only when you're putting your biscuits or you're putting your spacers, you want that hanging. Otherwise, rest of everything.
In that regards, the tip is you should not put the assistant should not put the hand under the popliteal fossa. It will not allow that flexion. It has to be under the thigh and leave the knee joint popliteal free.
Very true, very true. And other thing is the conversion intraoperatively. That becomes quite difficult in a hanging leg. I've done a few of them, but very, very challenging. It's So now then coming to the incision and approach. So you could either, I think once you start off, I think it's always good, like sir mentioned, you need to take a more extensive incision, go look behind the patella, look at the lateral compartment, not just the ACL. So how would you advise surgeons if they want to start off? Do they go in for a minimally invasive approach, or they start with a standard?
That is a big no. You start with, you don't hesitate to extend here and there, up and below, and open the joint. Maybe you don't need to go so much on the lateral side, like you evert the patella, try to evert that patella for a total knee. Don't do that. You just open it sufficient enough so that you just put small Homan and then see the lateral. Once it is okay, leave it. Don't go laterally anymore. But you will have the proper visualization of the ACL footprint, where it is, so that you don't go too medial, then don't go too lateral. All those problems will be avoided initially. Then over the period of time, you can
reduce the size. Yeah, Nikhil.
Sometimes what happens is there is a anterolateral big osteophytes, and that may be irritating that synovium, and patient has constantly anterolateral pain. So while doing uni, you also need to see that corner to remove that osteophyte, that sharp osteophytes. Anterolateral.
So you recommend a standard
No.
approach, or
You extend the knee.
and you can go
And if
in.
it is bigger, then you may extend somewhat.
So your skin incision is medial parapatellar,
No.
or it's
Oblique.
dead center. Okay, you take the oblique
Oblique
incision.
incision,
So what about Nikhil?
See,
You
I
you
will
like
suggest when you start beginning, go with a subvastus approach. That is the best approach you can get. The things
Subvastus.
for the uni- Subvastus, because
Okay.
you can convert that into total knee as well if you really want to do initially.
Mm-hmm.
And I think it is way rectus friendly approach. So that
Yeah.
rather than going for a minimally retinacular approach for the unis, you can start with the subvastus, and once you get used to it, I think you can take
Yeah,
any
so
approach whatever
I
you're
think,
comfortable.
To summarize,
Yeah.
with so many
Different
kinds
option,
and
yeah.
options, that's why I said, as an expert, you have that option of doing this way or that way. But for a beginner, I would say reasonably a midline, not a lateral, reasonably a midline, do a medial parapatellar. You start doing few cases of either a total knee or a uni like that, and then
Yeah.
slowly your incision will be little medial, little shorter when you become so confident that this case is only a uni.
Absolutely,
Then,
that's yeah.
Once you have done total knees in subvastus, then I can say you can
Yeah,
try
yeah.
it.
So there's many ways to skin the cat. There's not a fixed approach that you need to do it in. The Oxford guys have always, been big proponents of this oblique incision. But in case you need to come back later, to have an oblique scar is always an issue. So always look at it like Sir just rightly mentioned. Start off with your standard approach, how you go to the knee. So because you're going to do a more complex procedure, the UKR. So at least your approach initially should be what you're comfortable with, and then you can gradually modify and bring it down to a mini mid vastus or a subvastus, as Nikhil mentioned. So now we have exposed, we are looking, we have checked the ACL is good, the opposite compartment is good, patellofemoral looks good. Now we are coming to our tibial cut. So again, the esteemed panel, your tips of getting that perfect tibial cut, because this is, I think, one of the most important parts of a uni, to get that right.
Most important cut is that recip cut, vertical cut.
Right.
So it should be as lateral as possible. So as
based on those points, your varus valgus, what are you aiming at when you're doing
it
that?
should be perpendicular to your.
You're looking at
axis.
a dead perpendicular, neutral cut.
Yeah, neutral.
Correct. Okay.
So and slope, most of the systems ask for 7-degree slope.
Okay.
So that is okay, but excessive slope should not be there. And in advanced cases, like if the ACL is seems to be weak or
Then you
somewhat part of
reduce it.
avulsed, then
Yeah.
we may reduce the slope.
Okay. So do you like to go as per as your instrumentation system, that this is the slope that has been recommended, or you try and recreate the native slope? What is your choice?
I go according to what
Instrumentation says.
goes. Yeah.
Okay. And your depth of the cut, we just had a discussion
Yeah.
about that. So, 2 mm from the defect, where the defect is. So that's what you usually look at. And then based on laxity, you can adjust your cuts. And any tips how to avoid any medial plateau fractures, so when you're doing that tibial cut?
So recip should be a proper lateralized cut, and you never raise your hand so as
Yeah.
you cut posterior cortex more.
Very important.
That will actually eventually lead fracture.
You actually
It
breach
should
the
be
posterior
parallel
cortex.
to your
and then-
upper surface of the jig.
Correct. Very true. Nikhil, about slope, how do you go about it?
See, it always depends what the system dictates you, one thing. But once we started using a lot of robotics and a navigation based, I think I keep my slope according to what I really want. I don't want to go beyond 7 degree, that's my dictum. But I
Okay.
can cut down to the 4 or 5 degree depending on my ACL laxity as well. If I
Okay.
have a bit ACL lax, I would like to reduce my slope from 7 degree to 5 degree. I'll cut off that side. So with the robotics, definitely I take care of that slope myself. But if I am not using the robotics, I think it's a instrument based whatever instrumentation.
Right. I think the challenge is the companies are basically made out of Western designs, and they have recommended us the particular slope value. But Indian slopes are much more. So again, with robotics, that's what we've seen. The slopes are much more. So at least if we don't go above 7, but we come close to 7 and 8 at times when we are trying to recreate that. Sir, Natation sir, finally, any tips as to take that perfect tibial cut without causing a fracture?
2 important things. Don't go overboard and try to do a very medial cut trying to avoid the ACL. So the problem comes is you go fear of ACL, you go medial, and then the problem comes
Smaller.
And then either a small size, or you end up, when I showed an X-ray where the tibial tray overhanging. Problem is majority of them, that is the problem. We think it will not cause any. One is pain and early failure.
Okay.
Because of the biomechanics. That is one. Then the second thing is a deeper cut. These are the two things. Once you take care of this and select the right. See, another thing is when you are doing Oxford, the Oxford design is for Caucasians.
Yep.
The problem with this, the tibial side, where the smallest size of the Oxford will not even fit for the female patient. So that problem comes, and you try to take a bigger cut and try to put the next size tibial tray, and then you take all those problem come. So you have to be very, very careful. If that kind of a doubt is there, better do a total knee for that patient. Don't do a uni and then have a problem with this thing. So the tibial cut is very, very crucial.
Absolutely. So the take-home messages is, one is you don't breach the posterior cortex. How you avoid that is holding your saw absolutely parallel to the tibia. Do not lift your hand when you're doing it. Avoid a very deep cut. And I think when you talk about varus valgus, never go into a valgus cut on the tibia. That's the biggest problem. The keel would go very, very close to the soft part of the metaphyseal bone, and that's from where you can have a fracture initiating, fracture line starting. So you can be in neutral, or in fact aim for a little bit of varus, 1.5 degree of varus. With robotics we are doing that, 1.0. So you are away from that soft part of the metaphyseals where you could start off with a fracture. So these are the main 3 points I would say when you're thinking about a tibial cut in the UKR. So then coming to femoral component positioning, I think it's based out of the tibial cut, and it's usually jig based. But any tips and tricks when we are talking about intraprosthetic divergence, getting the femoral component absolutely perpendicular to the tibial component? I think that's very important. So do you draw a line on the femur? Do you?
You can, but majority of the time your jig will guide you.
Okay.
And also, it is unlike. It is little forgiving than the tibial tray. Even if it is little medial, little lateral, you should not be worried too much.
Correct. So this is what I was talking about, getting the component absolutely at perpendicular.
Picture perfect.
There is one of our Oxfords we did. So we try and aim for this. At times we go here and there, 5 degrees, but the Oxford or the mobile bearing is a bit forgiving because it's a completely congruent design. We'll be talking about that in tomorrow's talk.
That is what I was telling. So as a beginner, we have to aim for this. I've seen so many post-ops having this overhanging that we should avoid.
And how you achieve that is by going into the ACL. So when you're taking your sagittal cut, you might cut a few fibers of ACL. That's when you know you're right. When you're cutting those few fibers of ACL, not going into the substance, but you just chop off a few fibers of ACL. That's when you know that you've got. So it helps in two things. One is you get a good coverage, and second is the femur tibia tracking. That is much better when you have the tibia lateralized. And in a mobile bearing, you get something called as impingement. The poly tends to move forwards and backwards. So if your femur goes more laterally, your femur is going to take your poly along with it and impinge on the inner wall, lateral wall of the tibial component, and it can spin off. So you need to have that gap of 2 millimeter between the femoral component and the tibial component at the lateral edge of the femoral condyle. So those are tricks. Once you start doing the mobile bearing, it's of course a bit more, there's a learning curve there. Then, coming to balancing, what do you look for? Is it going to be tight or just neutral fit throughout, or you look for some laxity in extension?
No, you can, but to start with, To start with, I will say not to accept laxity, particularly if you are doing a mobile bearing. I will say don't have that laxity. That comes by experience because of the feel. At the end, it is the feel. Unlike a fixed bearing, you have to reasonably. The insert should go not too tight, but it should go with some pop sound. Okay. That is how I will take it.
Yeah, and Nikhil, in a fixed bearing, any particular?
So basically, you're just filling the gap.
Okay.
You don't want to over tighten. You don't want even the loosen gap for that place. Okay. So it's actually the feel, and it should go very easily, comfortably. You should not able to push hard inside. So that what the laxity you want, or you want to feel that time.
when you're putting your poly in.
But if you're using, see, what happens when a mobile bearing, you try to jam a bigger size, invariably in a fear of that biscuit will dislocate.
Absolutely.
Okay? And this
Excellent
reverse
point.
happens in a fixed bearing because you are leveraged. So you can undersize it and you can have a bit of laxity for the fixed bearing. Because you are not worried about the dislocation of the bearing.
Correct.
Fixed
bearing.
So that is a big thing. So if you are moving from the mobile bearing to fixed bearing, probably the thing changes. But we feel that it should be a comfortable.
Very, very important point. And when you start off with mobile bearing, I think all that is playing in your mind is I don't want my poly to dislocate. So the normal tension, when it goes in, you still feel this is loose. And what we tend to do is we start putting in thicker polys. And when you put in thicker polys, like in a total knee, you put in a thicker poly. If you're looking at the knee from the side, what you develop is FFD. If you put a thicker poly from a 9 to 11 or a 10 to 12. But in a uni, if you put a thicker poly, you're going to push it into valgus. If on the medial side, if you put a thicker poly, you're going to change the alignment, and that's not good news for patients. So, and that tends to happen when you start off your practice because we are just careful and we are only thinking about that poly not, slipping out. So, excellent point. Coming to alignment, what is your call, Bhupendra? Are you looking at getting it into neutral or just leaving it as it is if you are looking at a varus knee?
According to me, it is if these are varus cases. So some sort of varus may get corrected, but I don't want it 0-0 or in valgus.
Okay.
See, I always check my constitutional axis before going for unis. So with a scanus, okay? Yeah. And I wanted to maintain that constitutional axis, whether it is in varus, whether it is in neutral, okay? Both the things. So I'm aiming to correct the varus, but I am not in a hurry or I'm not in a position to correct entire varus. I can leave a 1 or 2 or 3 degree of varus if it remains.
Yeah. Actually speaking, if you are going to replace what you have removed, you should not correct anything.
Yeah.
You have to leave it how it was.
Correct.
And that is what, because you are just removing the damaged bone and putting in an insert, so you get rid of the pain but not the alignment. That should be the concept.
Yeah.
But as he said, maybe 1 or 2 degrees of correction invariably it will happen.
Sometimes you tend to have that slightly excessive varus, which is not beyond the indication level, but if it is slightly, you can bring it down, but don't correct it completely. You can come down to 3-4 degrees of varus.
Even a neutral will put a risk for
lateral compartment. So what we are trying to emphasize is once you go from that varus to neutral or valgus, you start loading the lateral compartment and the patient can have progression of arthritis and he'll come in with a failure in 4-5 years. So, and this is again a very important part of the UKR is your cementing of tibia. Because one of the most common modes of failure is loosening at the tibial sides. We do not have uncemented implants, so we are still looking at cementation. So your cementing game has to be spot on. So again, tips starting with Nikhil, when you're cementing the tibia, anything in particular?
First of all, you want to put a minimal cement in the uni compartmental. Okay, it's not like a TKI, you're just putting a lot of cement and then doing, because a lot of cement extrudes out and go behind and removal is very difficult. But yes, you have to pressurize. So what normally we do, we pressurize the cement in a metaphyseal bone before putting the tibial tray. So put a lot of cement and put that into the metaphyseal spongy bone and then a thin layer of cement on the prosthesis, and from posterior to anterior, you can jam the base plate.
Bhupendra?
So after like what Nikhil sir said, it is correct, but I allow the cement to set with trial poly in even in fixed bearing.
Okay.
And then only, then only if I remove excess cement, set up cement, and then only, because I don't want to have the tibia to have a chance of 1 mm movement while putting that original poly. I want it absolutely set there.
Yeah. So the idea is very thin amount of cement, but it has to be adequate, covering the surface. When you're compressing it, compress posteriorly and then anteriorly, so it expresses out anteriorly. And finally, Natation sir, unis are patients that we expect that they're going to do a lot of activities. Would you ask them not to do certain things?
It's very difficult to say not to do, difficult to say that once you have done a well-done uni, you do everything like dancing or anything. I don't tell them, in my practice, in my place. I don't tell the patient you do whatever you want. I
True.
will say you do normal activities, what you like to do, but don't go overboard. That's what I will say. See,
Correct.
like if I will not voluntarily go and say the patient, you can sit on the floor, sit cross legs, all those things.
Okay.
If the patient wants to sit, let him sit. But
Okay.
the most important thing is like using and squatting too much, okay, doing a marathon, going for a marathon too much, all those things is
You have to.
That's what I will say. You have to be
Yeah. Nikhil? Good.
Yeah,
Upendra?
with caution.
Yeah, you still.
total and uni are different. When we are talking about the survivors.
Correct.
So if you put the same indication for the unis and for PKs, I think survival will be more.
Correct. Yeah, yeah. So again, I mean, unis are implants that give you almost near normal activity. Yeah? But we have to caution the patients a bit about till what extent you can push those knees, because again, with the modern highly cross-linked polys, we are getting very, very good survivals. So I think that would be the take-home. These patients can do a lot of activities, but we always, convey to them that this can have a failure in case you overuse it, because usually sometimes it's done in younger patient age groups who want to do a lot of things. Yeah.
Because see, in uni we are maintaining all the ligaments, so the 4-bar linkage is intact. So obviously the natural feel what the patient get is much different compared to a total knee, and that is why patient want to do lot many activities they were doing,
True.
which they don't want to do when you do the TKR for the patient. So
Correct. Very, very true. I think so. With that, we are concluding this session of masterclass, because I think there's a call that downstairs they are starting off with the main conference. But in the meantime, if anybody has any doubts, you can ask us now or later on during the day we are here. So please do let.
Take one or two quick questions.
Yeah, sure. Yeah.
For the ones who start practicing uni, what should be the implant of choice? Whether to start with a mobile bearing or fixed bearing? What should
Basically, in which you are trained. If you have attended an Oxford course and you are confident enough, you can go ahead and do a mobile bearing also. There is nothing like mobile bearing is a tough one and a fixed bearing is a easy one. Not like that. If you are trained in mobile bearing, please do a mobile bearing. I started with the mobile bearing.
Correct. I mean, there's a study though which is told that the fixed bearing tends to be easier if your volume is less and when you're starting off. But then, mobile bearing, there's a very stepwise learning curve that is there, and the complications are slightly higher there when you start off. But like Sir said, you just have to be confident about it, and once you understand the philosophy how it needs to be done, it's an excellent implant.